Thank you. So I am so sorry I'm not able to be there, but as you all know, there are duties that we have in healthcare, and we also have duties when one of our loved ones had a healthcare need. And I'm taking care of somebody at home who's not recovered from a surgery fast enough for me to be present with you today. So I hope to continue this conversation, the presentation, as interactive as possible with the help of MD Expo. So let's get started. My name is Dustin Telford. I was already introduced. I'm with the ECRI Institute and with Healthcare Technology Strategies. I just joined ECRI about 2 months ago as a consultant with that group, but my career spans 30 plus years, primarily in the operations management and maintenance of critical equipment and some less critical. We're going to talk today about ventilators, and I want to get a poll of the audience just by, I was going to say showing of the hands, but I can't see your hands. So if you can raise your hands for the facilitator, I'd appreciate it. But I want to get a poll of who I am addressing. Like how many people are here for this training because they are interested in improving their skills on the technical maintenance of ventilators.
We've got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. I would say we've got about 70% of the class.
Okay, and for the other 30%, would you say that you fall into the category of I didn't see anything better on the list, or, and I'm going to say don't raise your hand yet for that one, or are you here because you want to improve your team's performance?
We do not have hands for that one.
Okay, well, I don't know if there's another option that I was going to bring up, but if somebody has something from the audience, please, chime in, let me know what they say.
Will do. Anybody?
Okay.
Nope, you are good.
Sounds good. Well, it's interesting because as I joined the pre-call for this call today, I saw that MD Publishing had a AI generated image that said AI is coming, and it looked like a storming robot. I took a little bit nicer approach with this image, but this is AI generated. Most of my images are going to be AI generated because I wanted to make sure that they were royalty free. I wasn't ripping off something that I can't, necessarily claim to use. So why ventilator maintenance is your ticket to being a healthcare hero? For those of you, the 70% of you in this group, it sounds like you were here to learn a little bit about ventilator maintenance, what makes them chug, so to speak, and how to make sure that they don't give you the dreaded vent in op or some other alarm at 2 a.m. in the morning. So why is it important? Ventilators are dependable machines that breathe for you literally or for your patients. When they decide to take a breather themselves, that's when trouble really starts. And routine maintenance is the difference between working like a charm and what's that alarm. Now, have you ever had a real reliable coworker that, I don't know, they never asked to take a lunch or a break, and then someday down the road they're just too quiet? If you were to listen for the sounds, and you've probably heard this already, if you were to listen for the sounds of what that coworker really does, how they sound, how they breathe, what shuffling of paper or what tools they're using, depending on what your work environment is like, you're going to see and hear, I should say, a lot more by that utter silence. And when the sounds are different, you know there's something up. So the one thing I want to bring up in this slide before we get anything out of the way is ventilators and maintaining ventilators. I have found it's important to not only understand what's going on with the electronics, but it's very, very important to use your senses, especially hearing in this case, to sense what's going on with the ventilator if it's making an odd sound when it shouldn't. Now, you may not know that right off the bat, but after you get accustomed to working on a particular brand of ventilator or ventilators in general, you'll get a feel for what those sounds entail, and uh, you'll know when it doesn't sound right, right? Kind of like that coworker that I started off with saying, when they're sick, you can hear it in their tone, you can hear it in their voice, you can hear it when they're not really saying much, but you can then say, hey, are you doing okay? It's the same thing with a ventilator, especially with those devices that run uh, heavily off of a mechanical principle. There are others, of course, as well. If your lungs just decided to quit because of a calibration error, it sounds a little ridiculous, but that's why we're here today, to ensure ventilators keep doing their job without any, let's call it, drama. Ventilators keep things breathing, so to speak, through 4 principles. Now, there are other components of ventilators that we can talk about and we will touch upon, but these are the main ones that I wanted to bring up today in the hour that we have. Pressure, volume, flow, and often, sometimes forgotten, temperature. They're the Fantastic Four. If you're a Marvel fan or even a comic book fan, you probably know about that superhero team, but they're the Fantastic Four of ventilation. Each of these components, pressure, volume, flow, and temperature, they work together to keep patients breathing naturally and safely. And small misalignments in any of these can lead to big problems. But there's no need to panic. We'll break it all down. In the group, how many of you have run into issues where one of these systems didn't play fairly or nicely in the sandbox?
We've got some hands going up, maybe 6 people.
Okay, why don't you pick one of them and then pick a different one on the next one if we have somebody that answers all these questions, I guess.
You want me to pass the mic to somebody?
Yes, please.
Who wants to answer? I have no hands.
Oh, okay. Well, not to put you on the spot, but when you raise your hands, you're volunteering possibly for the microphone in the future. But I will tell you that I've certainly had each of these act up in different scenarios with ventilators, and I can tell you that the tricks that we're going to go over and the troubleshooting tips are going to be immensely helpful when you are either doing routine maintenance, you're responding to an immediate need on the floor, or as I've done in the past, you're involved in investigations about why something didn't work. If you, oh, let me go to the next slide. Sorry about that. We're going to talk about pressure control first, or pressure in general. Pressure is one of those 4 key components that we're going to talk about today, and it's all about the right amount of push, right? Now, not too much, not too little, and we're going to talk about this, but the reason behind this will hopefully become fairly evident. Oxygen diffuses well in the lungs under a certain amount of pressure. If you were to go up to a higher elevation from a lower elevation in a short period of time, your body is going to have a hard time adjusting. The same is true if you go from, say, sea level to a 50 meters or so, or 20 meters underwater. You're going to feel that pressure against your body, and you're going to feel that pressure acting against your, say, scuba gear or the breathing apparatus if you're going up to, say, the peak of Mount Everest. But it keeps your lungs moving at the right force. So patients that are on ventilators often have a hard time with just the right amount of force or other aspects that we're going to talk about in getting oxygen to all areas of their lungs, and then doing that gas exchange and letting go, so to speak, of those waste gases, carbon dioxide. It matters because too much pressure can cause lung damage. If you were to imagine this, if you overinflate a balloon, you are possibly going to pop the balloon. It's certainly going to cause some stress until it pops. And we would never want, of course, somebody to have a popped lung, but it does cause stress on an already weakened system. And too little, as I already mentioned, too little doesn't allow oxygen to diffuse properly across the cell membrane. It doesn't allow oxygen to exchange into the lower parts of your lungs. And what I do want you to take away from this is that pressure is not just about how much pressure is controlled, but it's really about how much pressure is regulated by the ventilator. Sensors fail. Sensors fail without proper cleaning, proper inspection, proper adjustment. And we'll go into that a little bit again in the time that we have. But sensors are prone to failure, and when pressures are off, it's really game over. Most ventilators have some level of pressure control, a minimal amount of pressure, say for example, when somebody inspires or expires, a maximum level of pressure for when somebody expires or inspires. And before I forget, this is a good area to talk about, what if somebody coughs naturally? There are even most critical care ventilators have the ability to release a certain amount of pressure when a patient has their own force, if you will. And again, a cough, you wouldn't want that backing up, like, blowing up their own lung instead of just coughing out like you could naturally. Any questions from the group? I'm going to move on. If you do have questions, we can always move back.
I think we are good to go.
Sounds good. So the next component that we're going to talk about after pressure is volume. Now, don't get confused between pressure and volume. Pressure is the amount of force against the walls, say, of the lungs. And volume is how much air fills the lungs. We'll get into flow a little bit, but it's how much, say, at the end of an expiration, at the beginning of an inhalation, and at the end of an inhalation that really count. It ensures that you have the right amount of gas in your lungs. You don't want too little. And again, this goes back to diffusion across the cell membranes, or respiration, as we can call it. And of course, I didn't turn off my phone. So if you have not turned off your phone, it's a good reminder. I had an alarm go off that I didn't realize I had. Anyway, why it matters, of course, underfilling could be suffocation. Have you ever been short of breath? That's because you haven't had enough volume probably in your lungs. Overfilling can cause damage. It's all about the right balance. And one key takeaway here is regular calibration. And this is a common theme throughout all these, is keep ventilators delivering just the right amount of volume. Now that calibration is incumbent on you, the service technician or the aspiring service technician or the person that's a veteran. I'm not sure how many people are kind of nodding their head at each of these. But it's also incumbent on the respiratory therapist to make sure they make those tweaks and adjustments based on the clinical need of the patient. Flow sensors. Well, you can shove a lot of air into a patient. You can regulate the pressure, right? So you can take care of force and you can take care of volume, but how do you do it? And the reason why this is important is patients don't typically respond well, and over time, the technology has changed to accommodate this better and better. But patients don't respond well to an inrush of air that isn't tapered off in some way or that continues to be a positive inrush. Now, there are some ventilator technologies that are fairly constant. If you think about a CPAP, a continuous positive airway pressure device, CPAPs have generally, when they get up to their peak, whatever it's set to, they generally have a consistent flow with a few exceptions. But in critical care ventilators, remember, you've got a patient that can't breathe typically on their own or needs a lot of assistance in breathing. So you want to make those breaths as natural as possible. Airflow is critically important because you don't want to just say blow what is from the wall or from the tank in immediately and constantly. But at the same time, you need to blow in enough air and in any one breath or in any 1 millisecond. Disrupted flow can mean discomfort, right? It'll feel like somebody is choking, is starved, right? It's similar somewhat to volume, but volume is the result, right, of those points in time. Flow is what's happening in essentially real time. And flow is also important from a timing perspective. I mentioned that we weren't going to hit upon some other key components of ventilators, but flow is a matter of time. So if you aren't in sync with the patient's natural breaths, if you're trying to ventilate them too fast or too slow, even though they may be fairly comatose, to use a better word, I can't think of it right now, but they may be so sedated that it should not matter. Their body still wants to breathe at a certain rate, and you don't want to force them, from what I understand from respiratory therapists, you don't want to force them into an unnatural rate unless there's a real clinical need. Sensors, of course, they get clogged. They get clogged by things like nebulizing agents, humidity, and we're going to talk about one of the ways or one of the components here shortly about how to eliminate what's called rainout. But humidity and medications are some of the biggest killers of your sensors over time, your flow sensors. The other, and hopefully it doesn't get to your sensors as easily as just medication seems to, and humidity is bio waste, so to speak. Mucus, those sorts of things, aerosolized, can certainly affect your flow sensors. And the reason I say hopefully those don't get downstream as much as I unfortunately have seen medication get there is because my problem with that is that means you potentially have something else going on with your ventilator or the use of your exhalation and inhalation filters where they're not capturing enough of that gunk from one patient and it can be transferred to another with the vector, the ventilator. Now I mentioned temperature, or I mentioned how to prevent rainout, so to speak. Remember, humidity is a killer for flow sensors. Well, the right temperature is critical for a couple of other reasons I'm going to go into. It ensures that the air that you're breathing, or that your patient is breathing, I should say, is comfortable. Now, the key to this, and the reason I bring this up, is oftentimes, this is not regulated by the ventilator itself, but by the ventilatory system. And we're talking systems and breathing easier for patients. So the humidifier, right? Either if it's a heated humidifier, which generally that's where we're going to talk about with temperature control, but even a nebulizing humidifier, an aerosolizing humidifier adds a certain amount of heat due to the way they work with the technology. But heated humidifiers and some ventilators control that temperature flowing to a patient in a way that's in their comfort zone. If you've ever gone on a run or a walk when it's really briskly cold, you know that your lungs don't do as well or don't like the cold, right? The extreme cold. Now, if you're from Minnesota or you've been to Antarctica, as I have, it may be that you're used to a more extreme cold than, say, somebody who is born and raised in Phoenix. But an extreme amount of cold can be a shock to the system, and you don't want your patients going through a shock to their system when they've got a bunch of other things that you're trying to help them with. I should pause here for a second and just kind of point out that most patients who stay in an ICU setting will be put on a ventilator at some point during their stay. Numbers range from about 70% plus or minus. So if you think about it, you may have known somebody that's been in a hospital. If they weren't on a ventilator during their stay, they're in the during their critical care portion of their stay, they're in the minority. It's equally important and often forgotten that those humidifiers or the heated humidifiers are a central component to good delivery of care. So regularly check them and replace the temperature cells, the temperature assemblies, the sensor wires. There's a common brand out in use right now that has this PM requirement that actually checks the temperature cells or the temperature sensors. If you are familiar with Fisher-Paykel's preventative maintenance procedures have you check those sensors too if you have not, and I caution you on this, if you have not had a plan of tracking how frequently they've been used, how many times they've been used, and say disposing of them, the sensors themselves, before you come up to the PM instance of it. I think it's annual on those. But the reason why is because those sensors can fail, and those sensors can fail either gradually or they can fail catastrophically. If they fail gradually, you're delivering the wrong temperature to the patient because that feedback loop from the sensor to the humidifier is potentially off just enough that you are delivering either too cold or too hot. Now, I mentioned rain out, and before I forget, rain out is a problem of too much humidity hitting a cold surface after the air has been warmed. Some ventilators are actually designed in a way to prevent rain out. Some actually accommodate it by having a heated block or a warming block somewhere in the expiratory side of the ventilator pathway, the ventilator itself, so that the air that's moist and warm coming out of the patient continues to stay moist and warm until it gets out of the ventilator or past the flow sensor. The flow sensor and the pressure sensor to some degree do a lot better if they're not gunked up over time with medication and rain out or excessive humidity. Any questions or comments? Moving on. Remember I said these are all, oh, sorry, go ahead. Do you have something? No?
Sorry, my mic was taking a second to turn on. Do we have any questions? I think we're ready to move on.
Okay. Remember I said AI generated? I played around a little bit, and these are the 4 components that we're talking about. Disregard if there's any spelling errors. The AI image generator that I'm using, it's not good at spelling, and it takes several iterations, but I think it actually spelled these correctly, with one exception that it says flow and temperature combined. So these 4 components that we just covered are key to delivering what I would call the closest approximation to natural breaths to a patient. Now, I don't know that the technology will ever truly be there to deliver completely natural breaths to a patient, but the goal for any respiratory therapist and any manufacturer should be, and I believe is, to deliver as close to natural breaths as possible. So pressure control ensures that the right force is applied for safe airflow into the lungs. Again, too much, you will feel like you're actually choking or occluding somebody. And to use that balloon analogy, too much pressure or too much volume, which then causes pressure on the external walls, could cause stress on those vital sensitive organs, your lungs. Volume control, it delivers the perfect lung full of air, just the right amount, not too little, not too much, right? But the right amount of volume. And then flow sensors help in timing, not only between breaths, but also how the breath is delivered, either based on how it's controlled, either pressure controlled or volume controlled, or some combination thereof. But to rush, as I used this example earlier, to rush air into a lung would be detrimental to a patient, and to starve them, so to speak, to not give them enough airflow. So it's the right amount of airflow at the right time. And then temperature control, and again, I brought this into the 4 elements that I think are critical to a ventilator system because of that natural breath analogy, and to some degree to protect the components of the ventilator that do the other 3 things above, right? Especially the pressure and volume, or pressure and flow. But temperature control keeps the air at the perfect level, let's say, for humidity, comfort, but also to protect components of the ventilator itself. Here's a few troubleshooting tips that might help. If you can follow this diagram, please, please, please give that person a gold star. I don't know if we're getting a little chuckle, hopefully, but this diagram is bogus, right? I could have added in there, did you unplug it and plug it back in? If you're a fan of the IT crowd, this is not a good thing to do for a ventilator, as you probably are aware. Do not unplug a ventilator and plug it back in. But when you get a vent in-op, which is probably one of the worst errors to at least flash on a screen that I've ever seen, or a similar issue that says something is causing harm or potential harm to your patient, you want to do a couple of things. Check the basics. Check to make sure that your connections for your tubing are intact. Check to make sure that there are no leaks in the system. If the RT has recently done any sort of maintenance on the system, on the tubing, it's unlikely, but it does happen that they've disturbed one of the many pieces that go together on that tubing, including ports where they had some sort of drainage and they didn't cap off the drainage well. Anyway, it's likely that there's a small leak that, again, you might be able to detect through audible cues, but the best way to probably do this is to check all your fittings, right? Check the connections, make sure they're good. Check your power supply, make sure that your red outlets haven't somehow lost power and you just switch over. I have actually had that happen before. Unfortunately, the backup batteries on that particular ventilator were rated to perform for another 45 minutes, but it causes this panic moment for clinical staff because they don't understand the technical parts. Typically, they don't need to worry about the technical parts, that they have about 45 minutes, give or take, to find another outlet. But I've literally run extension cords over to the nurse's station, and I've seen some hospitals that I've worked for have backup batteries that they can wheel in immediately if emergency power goes down. There are some common issues that I'd like to talk about. Some of the common issues are calibration errors, not typically from what I've seen with biomedical technicians doing something wrong and then putting it up on the floor. But what I refer to as calibration issues is sometimes there are use errors and somebody has calibrated the device not knowing that they've calibrated it incorrectly, or not knowing that they were even in a calibration related setting and calibrated it and then put it on a patient. I can't emphasize this enough, but again, this is a simple and yet common thing that has happened that I've seen with some ventilators. In the room, are there folks that are familiar with like the Puritan Bennett 840 or 980 ventilators?
Give a show of hands. We have one.
Okay.
Oh, two.
So there's this. Yeah.
Sorry, you can go on.
Okay. So I'm going to use that as an example. It's a good example. Some ventilators have what Puritan Bennett called the gold standard tubing. This was a tube of a certain length and a certain compliance that you would hook from the inspiratory side to the expiratory side during the short self-test. The short self-test performed certain calibration verifications for the overall compliance of the circuit that you would hook up eventually, and then it would for the circuit. The EST did a lot more with that gold standard tubing. But if you're using the wrong tubing, or if somebody's pushing the button and going into the extended self-test, and they really don't need to from a respiratory therapist standpoint, they could be calibrating the device against the wrong standard. Again, that gold standard tubing, the few people in the room that raised their hand, and maybe there's one or two that forgot that they have worked on these, but that tubing was very specific, at least specific enough to give a different level of compliance than standard tubing that one would typically see in an adult or pediatric setting. So another common issue, I'll get off of calibration issues, but this is a good example that I just mentioned. Sensor failures. Sensors do fail. They fail for a lot of reasons, but just to reiterate, some of those reasons happen to be how clean the ventilator is over time and how long the ventilator has been used, period. Right? That's why a lot of ventilator manufacturers have explicitly said, do this off of an hourly or a metered basis, replace these components. They feel that it's important to do it at that level because they believe, for some reason, hopefully it's a good engineering practice, they believe that over time, that component will wear because of the environment and the conditions it's put through. The flow sensor at the exhalation side is a good example of this. It gets enough humidity over time, and if it's a heated wire flow sensor, it heats up enough that it burns off some of the wire over time, and its resistance changes. And then there's another common issue, and that's airflow blockages of some type. This will typically get resolved by the respiratory therapist, but you may be the first call, or you may be called almost right after the respiratory therapist because the nursing staff has observed this problem and they need somebody there now. So some of the quick fixes, and I call these quick fixes, are to recalibrate some of the settings. This is not something they would typically do with the patient on. You could clean the sensors. Again, not something you would do with a patient on, but checking for leaks or disconnections is a very quick fix for a lot of ventilator problems if you get called and everybody else hasn't found this problem yet. I have seen it, and it's gone both ways, where a respiratory therapist has recapped a connection that I just checked, and it worked then after that. We know then that it's kind of a faulty cap or faulty lure connection, but it goes the other way too. Biomeds might say, oh, you did all this? As frustrating as it can be to some of our customers, the important thing is that our patients are fine. And if you can go ahead and check some of these things yourself, you may be better off doing it than having somebody else check it, even with you watching them. This is one of the few non-AI images. I pulled this up at UAL. I kind of like this little checklist, but this is the pre-check routine. These are some of the areas that usually an equipment person or the respiratory therapist or the respiratory therapist is responsible for their equipment will check off these things and make sure that each of these things work. Now, are these labels often used? Probably not as often as just relying on the logs recorded on a more modern ventilator system, but it gives some important things to check for most critical ventilators. So start with your basic checks: connections, power, calibration. Check for leaks. Now, some of your pre-use checks, we'll actually test the system for leaks, and an unacceptable leak will typically result in a failed test, which you then have to go back and retest after hopefully just correcting it with tightening up the connections. Inspect your hoses, inspect the valves, seals for wear or poor connections. These are more in-depth for the biomed. The hoses are, of course, something that somebody can visually look at from the outside, but valves, seals, those are things that when you have the moment in time where you are doing scheduled maintenance, or if you've got a repair and it's invasive enough that you could check the other components or the adjacent components, inspect those valves and seals, see how they're wearing, see if they're clean, right? See if there is medication crystallizing on some of these components because it has found its way through that flow path. Small leaks are often the biggest issue that you'll see. And then I know it's controversial to some to say this, but user errors, most failures that I've seen in my career, and this is not me speaking on behalf of my employer, but I can tell you that most failures are preventable with routine checks. There's no gremlins, there's just simple fixes. Here's a few maintenance best practices that really apply to about anything, but especially as we're talking about ventilators, keep these things in mind. Partner with respiratory therapists for their daily checks. Make sure they're doing their daily checks or their pre-use checks before they put it on a patient. Educate them, observe them, go to their barbecues, and hopefully you understand what I mean by that, but be part of the team. I don't recommend that you do their daily checks for them. There might be an emergent situation for some reason that you would, or their pre-use checks, but the operator should be familiar with their device, and this is a good way to continue to keep that familiarity and assure that it goes on a patient in the best way possible. You should focus, and that's probably why I brought this up, is you should focus on your calibrations and your overhauls. Be exact. This is one area where I'll kind of mention a couple of additional levels that I like to do when I work on ventilators. Be exact, perform the in-depth calibration and adjustments. There are certain ventilators that over time I have become familiar with enough that it has been a nominal amount of additional time for me to go through the calibrations twice to improve the accuracy and the precision of the performance of all aspects. Some ventilators you'll do the calibration, say for example, for pressure, and then you'll do it for flow, and then you'll do it for volume. Now pressure, say in that example, if you adjusted pressure first, can be counter adjusted. It can go off just a little bit, right? It's still probably within tolerance when you adjust the flow and the volume. Go back and redo it. It tightens things up, right? You get everything in a tighter spec. That applies to some ventilators, not all. And another trick that I'll share with you is when you're testing a ventilator for a performance issue, remember all these components play a role more or less with each other. Test the ventilator itself for at least these 4 components: flow, volume, pressure, and temperature. Don't just say, well, I found a problem with the pressure sensor, it looks like, and I'm going to replace the pressure sensor. It takes usually a nominal amount of time to do the additional checks of the volume, say for example, flow and temperature, to assure yourself that you're ordering the right part or the right parts. I'm going to share a little sidebar with you. The best ventilator school that I ever went to, I was teamed up with a person that this is his first experience with ventilators. The instructors bugged the system while we were out of the room, and they would put a bad component in. I was already familiar with these ventilators, which kind of helped me, but it also was the best class I think I've ever been to for the following reason. They would bug it, we would go back and we would tell them what we found, and then we would replace it with a good part. Well, my partner, the way they partnered us up was people who with ventilator experience and without ventilator experience or limited. Well, my partner would go and get the new component, we'd put it in, and we'd leave the room, and then we'd have the instructors bug our system again. Well, on the second and third and even fourth, I think it came to this times we came in, I said, there's two problems going on with this ventilator, because I had been checking the other components, not just pressure and stopping there, or not just volume and stopping there. And the instructors could not believe it. We figured out that what my teammate was doing was he was pulling from the bad bin, the buggy bin, and putting in the bugged component for the one we were supposed to replace with a new component. And then the instructors were putting in a bugged component. If this makes sense, hopefully it does, but hopefully you're following. But basically we had two bugs. And it was great on so many levels because I was able to help, I believe I was able to help my teammate understand how to troubleshoot these things a little bit better than what the instructors maybe were kind of giving us at least, because I could see these problems were not just solely one component problems. And for me, it was a little bit more challenging. Anyway, so be exact. Perform 2 calibrations is one. Do all the checks instead of stopping and saying, oh, I found the problem halfway through the checks that you would do to identify a problem with the ventilator. This should be obvious, the schedule, but schedule preventative maintenance, including your part replacements and deeper inspections. I don't think I need to say anything to this group about that. But if I do, raise your hands, let me know. Okay, ensure the latest software is installed to prevent bugs and improve system compatibility. This is a good area to ask. Do you feel, and although this is not the impetus of this training session, do you feel by raising your hands that your organization has a good handle on patch and software management for their medical devices?
Do we have any hands? Oh, we've got one.
Okay. Give that person an opportunity to present maybe in April at the next MD Expo. Because, and what I would challenge you is that person that said that, maybe look around the room and look at somebody who really doesn't think they have it. Partner with them, because this is such an important topic that there are several sessions at conferences like this about patch management, cybersecurity, etc. But what I'm referring to is pretty much making sure that you have the right software installed at the right time, because every once in a while there is software firmware updates that come out from these manufacturers of ventilators. And then document. Now I will call it CYA for the obvious reason. You're covering yourself and your organization if you document what you did and how you did it. Now, I would go one step further and say document detailed enough that when you leave an organization or your mind starts fading, your memory starts fading, you can go back to the history on that device or the history of all of your devices and see if there is a reason to perform maintenance or repair in a different manner, or to be concerned about the age of the equipment and whether or not to replace it for that matter. I wanted to give you, and this is a pressure controlled block diagram. It really emphasizes a little bit more about what I talked about in the major components and some of the things that I didn't. I don't know if you can see my, arrow, but if you look in the lower left, I don't think you can. I'm trying to look at the audience view too. In
Yeah,
the
I'm not
lower
seeing
left,
it.
okay, there is one component that we didn't talk about, and that's the air and O2 proportioning system or the flow controller. Air and O2 need to be mixed at a certain ratio, depending on if you have an O2 source for your ventilator connected. Normally, we breathe 20.9% oxygen, give or take a little bit, depending on higher altitudes. Patients may need a little bit more of an oxygen-enriched environment, up to 100%. So this proportioning system is very important to get the right amount of gases, right, and the right amount of oxygen primarily to the patient to absorb or respire into their cells. But this does have a couple of components that we talked about, those flow sensors. There are flow sensors in some ventilators on the intake systems and pressure sometimes of the compressed gases or your wall outlet, middle of the screen. There's a flow sensor typically at the exhalation side of the patient. That flow sensor looks for normal conditions of flow, and there will be typically something for a cough so that a patient can cough on their own when they need to cough. They can force more flow through a restricted, normally restricted space because there's a sudden need to cough. And this, again, is pressure regulated. So going to the patient on the right side of your screen, you'll see the green thing, the green block that says inspiration valve. That'll be how much, something that controls how much pressure is allowed into the patient at any given moment in time, and how that's regulated over the course of the delivery of an inspiration and an exhalation. So typically, and very simply, at the end of an inspiration, that valve will either completely close or remain open for a minimal amount of pressure, what they will call an end expiratory pressure value, PEEP, positive end expiratory value. I don't see the negative much anymore, but we used to see it a little bit more in NICU patients, in infants. When that is closing or closed, the expiration valve is opening or open, allowing that pressure to be released out through that path and eventually out into, well, essentially the air. And on this diagram, I just realized it has a PEEP adjustment mechanism. And again, that is another way to choke off, if you will, how much end expiratory pressure, what you don't want to typically have the lungs go completely to zero. You want some amount of pressure, especially in failing lungs. So troubleshooting and preventative maintenance, anticipate issues, use data. I mentioned the documentation. That documentation is going to be important to you. It's going to be important if you are a technician today and you are a manager tomorrow, or you're the manager right now, or you're the clinical engineer. Use that data to predict and prevent future problems, and use it in an AEM program. Now, we don't have time to talk about that, but I will say that an AEM is perfectly acceptable on most medical devices. There's only 2 exceptions really, and ventilators are not one of them. An AEM can be doing more than what the manufacturer suggests to enhance the reliability or safety of that device. One thing I will suggest to you is if you do have something critical like a ventilator on an AEM, make sure that you consider at least giving feedback to the manufacturer about the reasons why you have decided that it's better to add some steps. They may actually incorporate that into their next recommendations as a manufacturer. Do your routine checkups. It's not good enough. It's never probably been good enough, especially on things like ventilators, to just see them once every 6 months, once every 10,000 or 2,500 hours. It's important to try and catch some of the small issues. If you have a relationship with your RT department, look at things, see how they're looking, see if they're being taken care of, see if there's cracks or whatever. And the routine checks category here too is also about your respiratory therapists, or those people that support the respiratory therapists, the equipment technicians. Those folks should be looking for minor things before they become major. To avoid downtime for a respiratory therapist, consider at least doing your work off peak hours to minimize patient care disruption. Now, what that means in respiratory therapy is not the same thing that I would suggest it means with, say, CT or MRI. But I'm so sorry I'm not there and I can't see you all, but some of you may know that I've worked in the pediatric environment for several years. And it is RSV season very soon. It's ingrained in me, and it's RSV season. It's not a good time to think that you're going to get access to all your ventilators during the months of October to April. Now, what we did is we tried to plan our preventative maintenance in, say, early October or October, because it's kind of the front end of that month, and in April, but the months of November and through March, it would have been probably a poor time for us to try and get all of our ventilators done. Document, and analyze that data. Don't just document for sake of documenting. If you're writing down electrical safety values, for example, I would suggest you don't. That's a whole other topic that anybody who's willing to talk to me about it, we can talk about. But there's no need for that in general, but there is, I believe, for other aspects like the volumes, the pressures, and the flow rates that you got on a particular ventilator, because it could come up in litigation about how detailed you were. It could come up as an important aspect about why maybe the ventilator worked and the user had a problem with it still. Does that make sense? Like a use error. So just a few final takeaways. Do your routine checks. Collaborate with respiratory therapy. Document everything. And stay current. Keep up with your software updates, calibration, and your new maintenance protocols, such as your AEM recommendations.